Hi everyone, we're going to talk about medication administration. This is Unit 2 in your Sumo Courses Study for CASAL 1. You can see a snapshot here of the different sections for Unit 2. You've got a My Nursing Lab module, an ATI module, an interdisciplinary care activity where you talk about the role of a pharmacist. You're going to read about medication administration in your clinical nursing skills textbook. You're going to watch your skills videos in My Nursing Lab, and then also we have a list of all the skills checklists in regards to medication administration. Medication administration is the second topic that you cover in your first learning lab. Here you can see part of the skills checklists for medication administration. I know it's an extremely intimidating list because there are so many. But the good thing is that they are all covering one topic and are pretty short. So don't get too intimidated. But do become really familiar with the different checklists, become familiar with medication administration, and I recommend doing all your reading before you go to that learning lab so that you can gain as much knowledge as you can on the skills portion because you've already covered the didactic portion at home. So one of the first things we're going to talk about is the different biochemical and physiochemical processes of medications. One of the words you're going to hear a lot is pharmacokinetics, and that basically in general terms just means how medication travels through the body. There's a different number of ways, and one of the first ones we're going to talk about is absorption. And absorption is the movement of the medication from the site of administration into the bloodstream. The most common route of administration are enteral and parenteral. Enteral, remember, is through the GI tract, and parenteral is through injection. The way I always remembered these when I was in nursing school and I was a student nurse, because I used to confuse them so much, enteral is when you enter the body. I know that sounds lame, but when you're taking a pill or syrup or something like cough syrup, you're entering the medication into your mouth, into your GI tract. Parenteral is, if you look at medical terminology, para is about or around, so you're going around the GI tract. So parenteral would mean basically the other routes besides through the GI tract. Whatever acronym you need to come up with to help keep those straight, do. I always found them confusing. Hopefully you won't. Distribution is the transportation of the medication to its site of action by body fluids. This can be influenced by circulation, the number of plasma protein binding sites a person has, and then barriers like the blood-brain barrier, the placental barrier, the milk barrier. So there's a number of different barriers that influence distribution, can slow it down or speed it up or stop it altogether. Metabolism is the changes to the medication into a less active or even inactive form by the action of enzymes. This is mostly completed in the liver, but sometimes in the kidneys, lungs, bowel, and blood. The metabolism of the med is just basically the breaking down of it. Excretion is the elimination of the med from the body. Typically it's excreted by the kidneys, but also by the GI tract in your stool. So you also excrete it through your stool. Pharmacodynamics are basically the medication's mechanism of action. And mechanism of action is how the med works. This is one of the things that I think as a student nurse is such an important process to look up on any new medication you're administering. When you're in your clinical rotations, you're going to get number of different patients, different floors. You're going to get their medication administration record in the morning. You're going to look up what meds they have due that day, when they're due. And if you're unfamiliar with the med or you don't know that much about it, I recommend looking it up in your Davis's Drug Guide, which is available to you in your Nursing Central software, and find out how it works. It's extremely important to understand how a med works, where it's metabolized, the half-life of the medication. This is all very pertinent to make sure that we're accurately dosing patients, that we are accurately following up and evaluating the effect of the medication. For us to understand all of those things, we really have to understand how the med works and what part of the body it works on. So it's really important. A good example of this, you can see example number 1 is the stool softener. What a stool softener does, its mechanism of action, is that it reduces the surface tension of the oil-water interface of the stool, which causes more fat and water to be absorbed into the stool, which causes it to be softer. That's its mechanism of action. Pain medications work on the pain receptors in the body. So those are different mechanisms of actions, and I definitely recommend becoming familiar with some of them and look up some medications. Maybe if you're on a medication, look it up. See what information you find out. It's pretty interesting. Different classifications of medications. Prescription medications are administered in the supervision of a primary care provider, which could include your physician, a family nurse practitioner, or a PA, a physician's assistant. All prescription medications have risks and benefits, and that's why they are prescriptions, because you will be discussing with your physician the risk benefits of taking that medication, any interactions it might have with other medications, the potentials for dependence and abuse for the medication, and the harmful effects. So that's why certain meds are prescription only. Uncontrolled substances are medications that require monitoring but don't pose a risk of abuse or addiction. A good example of this are going to be like antibiotics, non-steroidal anti-inflammatories like Motrin and naproxen, or insulin. These meds you can take often. Obviously you want to follow the instructions of your physician, but they don't pose a risk of abuse or addiction. You cannot get addicted to them, at least not physically. Controlled substances have a potential for abuse and dependence, and they are categorized into schedules based on how addictive they potentially are, and what the risk of abuse is for them. So each level has a decreasing risk of abuse and dependence. A Schedule 1 is going to be the most addictive, something like OxyContin. A Schedule 4 is going to be something like a sedative or a hypnotic, something that potentially has risks for abuse but isn't quite as addictive based on its chemical makeup. And so it's not as high warning. Obviously, doctors want to start with the least addictive or risk for addiction medication that they can for each patient. We want to start with the least invasive, moving to the most, risky as we deem necessary. So different routes of administration. The first and most common one is oral, or PO. You'll see it written a lot in the hospital. PO is the abbreviation in medical terminology for by mouth. Some of the things that we have to be aware of and make sure a patient has before we can administer an oral medication are that they have a gag reflex, that they're alert and oriented, they're not confused. We want to make sure that there's not any contraindicated food or drinks. Some medications you can't take with certain juices, like grapefruit juice. Some you're supposed to take on an empty stomach. Some you're supposed to take with food in the stomach. So it's very important to follow up and see if there's any special requirements for taking a PO med. The sublingual medication is a medication that dissolves easily. It's placed under the tongue. Underneath the tongue is extremely vascular, and so things are absorbed quickly into the bloodstream and typically easily absorbed. You don't want to chew the med, you don't want to eat or drink while it's in place, but typically they absorb really quickly. Nitroglycerin is one of the most common sublingual medications that you'll encounter. Transdermal route of administration is going to be when you are going through the skin, or through, literally in medical terminology, trans is across dermal skin, across the skin barrier. The most common medication we use in a transdermal way is going to be the nicotine patch. A lot of people are familiar with that. One of the new things that they're doing a lot with pain medications is also using the transdermal approach, using pain patches to give a consistent level of medication. Transdermal medications tend to be longer dosing, sometimes up to 3 or 4 days, depending on the medication, and they tend to give a steady level of the medication. When we apply them, we need a clean, dry area of the skin. It's got to be pretty hairless. We rotate the areas in which we use. We don't want to keep a patch on the same place. So if we have a patch you wear for 72 hours and you put it on the right arm, you don't want to put it right back, when you replace it, you don't want to put it on the right arm again. You want to rotate it maybe to the left arm or to a different spot on the body that's applicable. You don't want to cut transdermal patches, and you always want to wear gloves because the medication is embedded in that gel base on the back side of it. A topical medication is going to be like a cream or an ointment. Antibiotic cream is a topical medication. We use these a lot, and we typically apply these with a glove or a tongue depressor, cotton applicator, one of the above. Just depends on where we're putting it and why we're putting it. Installation is when we are putting drops in the eyes and the ears. These can be various medications, a lot of times antibiotic drops, but they tend to have very specific instructions that go along with them. So being real clear on the instructions that go along with the medication is important when you're talking about installation. Inhalation is going to be like an inhaler. The most common thing that we hear about is an albuterol inhaler for asthma. With an inhalation, we are typically exhaling or having the patient exhale completely and then inhale as the meds are going in, and kind of hold their breath and make sure that we're taking that medication deep into the lungs. Nasogastric and gastrostomy tube are tubes that go directly into the stomach. Nasogastric tube, as the name implies, enters through the nose and goes down to the stomach. The gastrostomy tube is a tube that is on the exterior of the body and goes directly, it's inserted directly into the stomach from the outside. Before we give any medications in either one of these, we want to check tube placement. You want to use gravity, so we're not pushing something very quickly, and we want to make sure that along with other routes, we're going to check compatibility of the medications that we're administering. A suppository is something we use often for constipation or severe constipation. Occasionally, if someone's having severe nausea and vomiting and can't hold any medication down to help with their nausea or vomiting, and for some reason they don't have an IV, we'll give them a suppository for that as well. Suppositories are generally inserted just past the rectal sphincter. If it's something to help them poop, we ask them to hold it in for 20 to 30 minutes. If it's something that is going to be a medication that we want systemically absorbed, it'll typically be in for at least 60 minutes. Injections. This is one of the things that you guys are going to be exploring a lot when you start holding and handling needles, looking at the different sizes and the different gauges within your labs. An intradermal injection is going to be within the skin. All of you at this point have had your PPD test or your tuberculosis test. A lot of times they will inject a small wheel of medication into the skin itself. That's an intradermal injection. For an intradermal injection, we only want to use very small amounts of fluid. It's going to be 0.5 0.01 mils to 0.1 mils of medication, and we use a very fine gauge needle, so 26 to 27 gauge. Remember, with needles, and it comes to gauges, the higher the number, the smaller the needle as far as width. In addition to the gauge, we also look for the length of the needle, and the length is determined by where we're injecting that as well. A subcutaneous injection is for a small dose of a non-irritating medication. It will be a water-soluble medication. We use short, fine needles because it's only going to that fat layer just beneath the skin, so it doesn't need to be deep. Typically we use a 3/8 of an inch to 5/8 inch length needle because we're not introducing more than 1.5 mils of medication, and so we tend to use a 25 to 27 gauge needle. The most common subcutaneous injection we do, or that you're going to see, is going to be insulin. We do this a lot, patients do this a lot, and you'll see those insulin syringes, and that is for subcutaneous injection. Most common type of intramuscular injection we give is for vaccines. I'm sure you guys have all been very lucky recipients of your tetanus shot in the last few years. That's an intramuscular injection. They're typically given in the deltoid of the arm or in the hip. We use it for more irritating medications or medications that are solutions in oils. We need a bigger needle size because it is generally thicker fluid or greater volume of fluid, but not more than 3 milliliters. And the needle needs to be a little bit longer, so 1 to 1.5 inches, because it's got to get past that subcutaneous layer and into the muscle. IM injections are very common. Like I said before, the majority of the ones we do are vaccines. In the hospital, you'll give some other types of medication, sometimes Toradol in the hip. And we determine, if we give it into the deltoid or the hip, or sometimes even the quad, based on the medication. And the reason we give certain meds into the musculature is because the muscles have a greater vascularity. There's a lot more blood flow. So in irritating medication, we want to be absorbed, but we don't want it sitting there irritating the heck out of that muscle or that tissue. We want it absorbed. So we put it someplace more vascular, and that's why we choose the muscle. Intravenous injection is going directly into an IV. When we administer medications in the IV, we are really having to choose many different things other than when we start the IV, we choose the catheter size. On an IV, for those of you who haven't started one yet or haven't played with an IV catheter yet, you'll see that there is a needle, and then over the needle there's a small, very thin, flexible tube, which we call the IV catheter. When you introduce the IV or you start the IV, you put the needle into the vessel. We determine that the needle's in the right spot by getting a flashback of blood. Once we are in the right spot, we then pull the needle out, and that catheter, that small piece of plastic, stays in there. That plastic is kind of like our little pipeline directly into the vessel so that we can give medications. Now, there are different sizes of IV catheters. We tend to use them for different reasons. If we have a trauma patient, someone that we're going to need to give a lot of fluid very quickly, or potentially a lot of fluid very quickly, we start a bigger gauge catheter, 16 gauge, or 18 if they're having surgery. And the reason for this is if you think about a hose, you can put a lot more water through a fat hose than you can a skinny hose. And so we need a bigger catheter if we have to give someone a lot of fluid quickly. Someone who's having surgery or just might need medications, or maybe for a child or an elderly patient who's very stable, we don't need that big of a catheter, so we could go down to a 22 gauge, sometimes 24 gauge for children. And we also start very distally, so peripherally. We start in the hands, the forearms. We save the antecubital space, which is that crook of the elbow, for trauma patients when we need access to a bigger vessel. Epidural injections are when we give medicines through an epidural catheter, and the epidural is started very similarly to an IV, where there is a catheter placed after the anesthesiologist places a greater size needle into the epidural space. They then kind of put this very small flexible tubing directly into that epidural space. They pull out the needle, the plastic stays there. Then they're able to insert opioid analgesics directly into the epidural space, allowing for a smaller amount of medication to be given, but given in a very direct spot in order to help pain or possibly numb someone. When we're talking about getting medications, we have to think about certain pieces of assessment data that are pertinent to giving medications. Age is a very big factor. Babies, young children, and then older patients have different levels of metabolism and different rates of excretion. Those are things we have to take into account. Older patients often metabolize things slower. They also excrete them a lot slower. So we have to be cognizant of what we're giving them and how often, so that we can make sure that we aren't damaging their kidneys, say, as the kidneys are trying to metabolize those medications we're giving. Gender and body build makes a difference. Women, men, women tend to have more body fat, less musculature, less overall body weight, so they might require less medication than a man who's got a greater body mass. Chronic disease, having a chronic disease such as kidney failure or liver disease will affect how medications are metabolized and also how they're excreted. So we have to be aware of any chronic illness a person might have so that we don't overload them with medications. Any concurrent medications, we want to make sure we don't have any interactions with other medications, and that can mean a heightened response or it can mean a canceled response. Certain medications like antiemetics or medications that stop vomiting in conjunction with pain medications will potentiate each other, meaning they have a greater response because they were both given together. And in the inverse is certain medications will cancel each other out. Okay. For instance, if you are taking antibiotics and you're also on birth control, they tell you to use another form of protection because the antibiotics will kind of cancel out the effect of the birth control and make it so that it doesn't work as effectively. So just being very cognizant of potential interactions with other medications. First pass-through effects, this is something that's not as common, but some medications when taken by mouth are inactivated completely their first time through the liver. So sometimes they will have to be given by another route or even increase the dose so that they will work on that patient. Other things to be aware of, nutrition status. We have to be aware of whether or not the patient's eaten. Because, like I said before, some medications are supposed to be taken with food, some are supposed to be taken on an empty stomach, some aren't supposed to be taken with certain juices, so we just have to be aware so that we can work around that. Pregnancy changes the entire circulation of a patient. Hormonal changes can exacerbate or lessen someone's threshold to certain medications, and just having an overall increased blood supply changes how much medication a woman might need. And it also can slow how much the woman is excreting a medication. So pregnancy brings a lot of changes too that need to be talked with the physician about. Psychosocial variables that will affect medication response or use. The health benefits. Previous experience with meds. If someone's had a bad experience with the medication, they're less likely to want to take it or will think that there's more of an adverse effect. The patient's knowledge based on the medication. It's very, very, very important that we are educating our patients about why they're giving it, potential side effects, dosing, potential interactions, all of these things. It's very important that they are given all of that information. Cultural beliefs. Some people are just not going to want to take medications for cultural reasons or religious reasons, and that's their right. We just have to be aware of those variables so we can manage that. Social financial status. This is unfortunately something that comes into play a lot with our older population, and just the logistics of being able to afford their medications. Some people just simply cannot pay for them. So they might get a prescription and might never fill it because they can't. So this is something to be aware of, especially since there are other, typically there are alternatives. Very rarely do we have a medication that only is one medication for a particular issue. Often there are other ones that might not cost as much, maybe they don't work quite as well, but might be a good alternative in this situation. Another variable that we have to be aware of is the potential for abuse and dependence. Unfortunately, this is something that we have to be very aware of and recognize early on and educate patients on as well. As far as safety and medication administration, know your 6 rights. This is something you have to know. You have to abide by. This will never go away. It's been around since I've been in nursing. It hasn't gone away. In fact, when I started nursing, there was only 5 rights. Now there's 6. So it has changed. You want to make sure you've got the right patient, the right medication, the right dose, the right time of dosing, the right route, and then that you're documenting right, and making sure that it is documented appropriately, and also that you're documenting a response or an evaluation of how well the medication worked. Some of the most common errors include giving the wrong med or the wrong IV solution, giving an incorrect dose or running an IV at the wrong rate, giving the wrong patient the wrong medication, or maybe giving it at the wrong time or the wrong route, giving a medication to a patient who's got it listed on their allergy list, just plain forgetting to give a medication, discontinuation error, meaning that a physician has decided to discontinue it, and for some reason it hasn't been taken off their medication administration record, and so the nurse goes ahead and gives it anyway, even though in the orders it'll say that it was discontinued. And then sound-alike drugs. There's something called look-alike, sound-alike drugs, where meds sound the same and are very similar, but aren't the same. So we have to be very, very Thank you. Some of the things that we can do to reduce these errors are just utilize your nursing assessment, your nursing process. You use your assessment skills to make sure that we've got the accurate information from the chart, we've got the right client, we've identified any risk factors, to know the important information about the medication, to check the label on the medication to make sure it's the right one, the right concentration, and to make sure that we don't give it if we believe it to be unsafe or that we need to verify something first. You're going to plan, and in that you're going to calculate accurately, you're going to double check, you're going to avoid distractions when giving medications to eliminate those potential interferences. The implementation, you're going to follow your 6 rights when you're giving the medication. You are going to know the route, you're going to communicate clearly in your writing and your speaking, and make sure you're always following those 6 rights. If you follow those, then you will be safe. And then you're going to evaluate. You're going to make sure that the response that you are seeking with the medication is the response you got and that you documented it properly. You're going to evaluate to make sure that you're recognizing any adverse effects, and you're going to make any changes according to that effect. And then you're going to report all errors. That is it for medication administration. Sorry we rushed to that last part. There's a lot of info in that one. Please let me know as you go through all these. If you have any questions, just shoot me an email and I'll be happy to help you. Take care.